Good afternoon, everyone, and welcome to today's program, which is about coronary physiology. And the question if a new pressure guidewire design may expand the adoption. I'd like to introduce myself. My name is Dr. Tim Schäufele. I'm a consultant at Lindenhospital and University Hospital in Bern, Switzerland. And I've got the great pleasure to be here today with a really fantastic faculty. And I would like to introduce to you Dr. Ewald Christensen, Associate Professor from the Cardiology Department at Aarhus University Hospital in Denmark.
Hello.
And Dr. Pasi Karolainen, who is an adjunct professor in the Cardiology Department of Helsinki University Hospital in Finland.
Hello, Tim.
So you see, today we are not really very Mediterranean, and of course, today's broadcast is supported by Opsens Medical and is brought to you by Radcliffe Cardiology. I would like to start with some kind of housekeeping. I would like to remind you that this should be a very interactive session. So please feel free to submit your questions to the faculty via the question module on the webpage, and we will try to answer as many of them as possible towards the end of the webinar. Also, please keep in mind there will be live poll questions throughout the presentations. So I would like to encourage you to participate with those by selecting the multiple choice questions on the webpage that will appear as we go. So before we start, just have a short look at our agenda. The first case, the presentation by Professor Christensen, and which is directly followed by the one from Professor Karolainen from Helsinki. And we will have time to discuss any upcoming questions in the live Q&A session at the end with the whole faculty. And I think we have prepared enough time to do so. So I hope we will have a very interesting discussion. So finally, when nothing is left to debate, we will have our short summary and we will close. So what are our key learning points today? First of all, we would like to examine with the experts the current major barriers to expand the adoption of coronary physiology. As maybe many of you will know that there's only about a 30 to 35% penetration in interventional cardiology. We would like to discover the advantages of the new device, the Optiwire 3 pressure guide wire, in overcoming maybe part of these barriers, supporting in full safety the physiology assessment of complex PCI. And we would like to discuss whether the wire technology innovation can be the third milestone to, well, increase the adoption after clinical evidence and non-hyperemic pressure ratios. So to shortly bring us all to the same page and just give a small teaser at the beginning, we all know these situations. So there's apparently not subtotal stenosis, and the question arises, is this 45 or 75 or 95%, and what do we do? Do we go for stent or bypass or for OMT? And most of you will be aware that the diagnostic yield of coronary angiography alone has turned out to be rather small. So it's about 65%, and compared to coin flip, which is 50%, that's not really an advantage. And that brings us to the level of this gentleman here from the year 1553, who was without any doubt an expert in his field, but had to rely on optical impressions when looking at patients' disease. So what we would like to demonstrate is that things have changed. As all of you know, they have found their entrance in the current guidelines, and we would like to demonstrate that coronary physiology has many more advantages and the potential to guide decision-making in complex PCI. And with this, I will let you to the faculty and I will hand over to Ewald, and we're happy to see your very, very interesting case.
Thank you very much, Tim Schaufeler. If I can have my slides, it's entitled The Use of Physiology and Imaging in the Guidance of the Left Main PCI. And before I give you the case presentation, I have a question for you that I encourage you to answer. And at the end of the presentation, you will see the result of this poll. So, how do you usually evaluate a possible suboptimal circ ostium after stenting the left main in a provisional stenting strategy? Do we try to optimize the angiographic projection for stenosis evaluation and look at the TIMI flow? Do you use imaging from the LAD to the left main with IVUS or OCT? Do you rewire the circ with a pressure wire and measure resting indices or FFR? Or do you open the strut with a small balloon and use imaging with IVUS or OCT? I'll give you some time to think and to press what you do in this scenario. If we look into the recent consensus document from the European Bifurcation Club, it's just published in Eurointervention. It's rather vague. They say that side branch intervention is recommended whenever the result of the side branch is considered suboptimal. Doesn't help us very much. However, defining a suboptimal result for the left circ ostium is difficult and not standardized. In the supplementum of this paper, you can see how it was done in trials. You could use visual angiography. In bifurcation, Nordic bifurcation study 1, we just looked at the flow and encouraged to use treatment of the side branch if the flow was reduced. In Nordic bifurcation study 4, we also looked at the diameter stenosis of more than 75. And in BBC, they also looked at the dissection in the ostium. And that was the criteria for doing something for the side branch. In Korea, by Co, they looked at the FFR in the side branch, and if it was reduced, it should be treated. In the October trial, we use imaging and we look at the side branch minimal diameter of less than 50 of the reference diameter. And in that situation, you should treat the side branch. So this is just what I used in trial. This is not strict criteria for what to do. So my case is an 83-year-old lady with type 2 diabetes, reduced kidney function, new onset cardiac failure, and a reduced ejection fraction to 25, left bundle branch block. She was put to the CT scan and it showed very high calcium score, and they had the suspicion of left main disease. When she came to angiogram, she had edema, saturation of only 85, and she was uneasy on the table. So nothing ad hoc was done. We had the chance to plan for a PCI. So the left coronary angiogram showed no significant stenosis. The left main, pressure damping in the ostium, and the distal left main disease, but not so much disease as in the ostium of the LAD, of the circ, sorry. So the strategy was that we wanted to have a quick procedure. We want to have low contrast. We want to do IVUS guidance from the LAD to the left main and physiology guidance in the circ radial procedure with 6 French. And we want to go provisional from the ostium of the left main into the LAD. So first we put in a wire in the circ and then did imaging in the LAD to identify a landing zone. We identified a good landing zone in the LAD. We saw that there was circular calcium in the ostium of the LAD and also in the distal left main. From IVUS, it seems that the circ was quite open, but you have to be aware that the oblique view can give you a false impression of a good flow area into the circ. And then with the pressure wire, the Optiwire 3 in the circ up front, there was no significant pressure drop there. It was 0.90. So we did pre-dilatation. We wanted to crack the calcium with scoring balloon at high pressure. We did several scoring balloon dilatation with the Optiwire 3 in the circ, so we could follow what happened in the circ during this maneuver. And then we put a stent from our identified landing zone in the LAD to the ostium. We did POT with 4.5. And after POT, the pressure reduced in the circ to a diastolic pressure ratio of 0.67. That told us that we had to do something from the circ in this provisional strategy. What should we do for the circ? Is kissing enough? What do we have to stent? It was very easy to advance the Optiwire more distal to the circ, and then by pulling back, we could see that the distal lesion in the circ also contributed to the pressure, to a pressure drop. So therefore, we decided to stent long into a healthy-looking segment in the circ. Sometimes operators forget to pre-dilate the circ in the provisional strategy. So we also did good dilatation with scoring balloons in the circ and converted to the culotta stenting. After we have done POT again, and then we control the results with IVUS. We had good stent expansion in the left main, in the LAD, and also in the circ ostium. And the circ looked quite healthy with a normal 3 layers distal to the standard area. So we were happy with this result. So how do we do a quick evaluation of the circ in the left main in the provisional stenting strategy? Can we use the angio? The guide cannot be intubated to give sufficient contrast filling because we have a jailed wire in the circ for protection. And the circ ostium often shows ambiguity on angio. In 40%, we estimate that we cannot get a free projection of the circ due to the constraints of the C-arm by angio. And what about IVUS from LAD to the left main? It gives us inadequate pictures due to angulation and also because of stent shadow. OCT, we had low EGFR, and it only shows the very proximal part of the circ, and cut plane analysis is not commercially available yet. What about physiology? Yes, a jailed wire can be give quick information on the effect of stenting across. So I would like to conclude in this case that the Optiwire 3 can be jailed during left main bifurcation stenting. The wire can be moved up and down after jailing, and the measurement guides us to step up to kissing if there's a short pressure drop, or to two-stent technique if it's a longer lesion. Interested now to see the answers for. So optimize the angiographic projection for stenosis evaluation unit flow, only 11%. Imaging from the LAD to the left main with IVUS or OCT, only 22%. And people tend to want to rewire with a pressure wire and measure resting indices or FL bar. And I hope, and nobody wants to open the strut to do imaging. I hope that this case illustrates for you that there's another answer to this question. That is that you can upfront put a pressure wire into the side branch and get quick evaluation, and you don't have to struggle with the rewiring. Because if you don't have to do something, if the pressure is okay, you don't have to spend time of rewiring the circ if the pressure is okay after stenting across with POT. So thank you for listening to this case, and I will bring back the word to Tim Schaufelder to take it from there. Thank you.
Yeah, thank you very much, Dr. Christensen. This was a really very elegant and I think very clever solution to this complex case. So we will have time for questions after this next presentation, and I'd like to remind you to keep submitting your questions with the polling with the question system. We will cover them at the end of the session, and we are right on time. So I would like directly to hand over to Finland, to Dr. Pasi Karjalainen, and we are happy to see your presentation.
Okay, thanks again. And It's my pleasure to be in this session and to give a nice case from Helsinki, Finland now. So this is my patient. He is 62-year-old and he has been quite healthy earlier, no previous medication. Of course, he has been smoking and there's a dyslipidemia without medication. And early January, he had a sudden chest pain and STEMI was diagnosed and primary PCI was done to right coronary artery. Here we can see the troponin elevation and ejection fraction, which was normal. And there was also lesion in the LAD, and there was a plan to have a staged procedure for LAD in the same hospitalization. So here we can see the poll question about this case or this clinical situation. So please reply or answer the questions, which is how would you treat a STEMI patient with this kind of profile? Only the culprit lesion and maybe the LAD someday later, full revascularization and angio-guided revascularization or physiology-guided revascularization in this case. And let's review the case. Angios. So this is the right coronary artery, which was treated 8th of January, and drug-eluting stent was implanted in right coronary artery. Result is quite nice. This is 3 days later, when there was a planned staged PCI for LAD. So right coronary artery is nicely open. And here we can see left. So circumflex was normal, but here we can see that in LAD diagonal bifurcation, there is a stenosis. Diagonal branch, it looks like quite nicely, but there is maybe Medina 110 lesion in the bifurcation. So the plan was to do pressure wire with measurements with the Optiwire 3 novel wire. Here we can see the wire in the LAD. And first we measured a resting index, and this was 0.92. So this is more or less normal. So in some cases, we could have stopped here, but we also did FFR. And we can see that the FFR is 0.77. So we decided to proceed for LAD stenting. So this is the angio after wiring. So the Optiwire was left in the LAD, and the plan was to do PCI by using this pressure wire. Pilot 50 was inserted to diagonal branch. And this is angio after predilatation. And we can see that the result is suboptimal. Of course, diagonal is still nicely open. Then next step was to implant a stent. Once again, drug-eluting stent. This was Orsiro 3 and 18 millimeter stent. Result is quite nice, but now there is a tight stenosis in the diagonal ostium, so there is a black shifting or spasm. And next step was to check the LAD result in the LAD stent, and we can see here that the DPR was 0.91. And after that, we decided to exchange the wires. So the Optiwire pressure wire was inserted to diagonal through the stent struts and pilot to LAD. And here we can see that the wires are in the Optiwire is in the diagonal branch. And once again, we measured the resting index. And here we can see that from the diagonal, DPR was 0.78. So additional ballooning was decided here. And actually we used truck coated balloon 2.5 and 10. And after the truck coaching balloon, the TPR was a little bit better. It was 0.89 at this stage. And here we can see the result. We also did the POT in the LAD, and in this angio, this is a still image. The vessels, both LAD and diagonal, they are quite nicely open. So after the POT, the pressure wire is still in the diagonal branch. After the POT, the TPR was 0.90. And finally, here we can see the final results or result. And we also did a TPR pullback. And on the left, you can see that from the diagonal, TPR was at the start of the pullback 0.93, and in the left main it was 1.0. So there were no drift in this clinical case. So briefly, a case summary. So in this case, it was easy to wire LAD with the Optiwire 3 novel pressure wire, and I believe that we had a reliable lesion analysis with the pressure wire. Also, it was easy to do the stenting through by using this wire, and wire change was also easy. So it was quite easy to put the wire through stent rods to diagonal, and once again we had a measurements, reliable measurements, TPR measurements from the diagonal, and also we finished the procedure with the diagonal truck coating balloon dilatation and also POT in proximal part of the LAD stent. And after the procedure, we noticed that there were no drift with this Opsens Optiwire system. So what about the poll results? So as we remember, this was a STEMI case, and 3 days later we had a second procedure for LAD, and 18% of the answer says that they would have treated only culprit lesion, and 82% was probably like the same approach that we had in this case. So I would like to thank you for your attention. And please, Tim, you can continue from here.
Well, Pasi, thank you again also for this very, very interesting case with showed a couple of pearls, especially in bifurcation stenting. And I would now like to start with the Q&A part. There have arisen a couple of interesting questions. And first of all, just would like to comment on the polls. Apparently, we are either preaching to the choir, or the audience seems to me a little bit biased, because physiology seems to be the way to go for all the decisions to take. So I would like to start with one of the questions that have come up. It goes to Ewald. So the question was, in what percentage of left main cases are you using the Optiwire to evaluate the hemodynamic relevance?
For me, I must say the wire is new for me, so I'm just taking it into the clinical use. So the technique by jailing a pressure wire, I have not adopted yet. I want to expand that, and I want to test it further, but I felt that I could easily move it, and I think I'll use it more now because it takes out a lot of complexity that you can, if you stand across and do a POT and the pressure is okay, it's a very quick procedure. Yeah. So I cannot tell you any percentages now. It's too early stage.
It's definitely something that has really found its entrance in your daily practice. So I mean, what we discovered with all this physiology equipment is that ease of use is one of the key elements. So would you in the left main rather go for diastolic resting index like the DPR, or would you rely on the FFR?
I think I'll think in the same way as Pasi, that I'll start with the diastolic indices. And if it gives a clear answer, I don't want to spend the adenosine. Another thing is that when the guiding catheter is hanging out in this scenario, and you cannot push it in, and are you really sure that you're getting all the adenosine into the left main? So this is also an advantage, that we have both options, that we have the diastolic pressure and we also have the possibility to go up. In this scenario, I cannot push the guiding catheter in and be sure that it comes in.
I think this is a very important point, because if we look at the Excel IRIS sub-study, I remember that I think about 25% of the left main stents being implanted up to the ostium have been deformed by deep intubation with the guide. So I think this is a very, very important topic. So just go to the next question, and this goes to Pasi. It's, how about post-PCI physiology? Is this really needed to optimize? Could you comment on this?
Well, of course, if you are doing the PCI with the pressure wire, then it's quite easy to check after the stenting the resting index. I don't do FFR measurements, but only the resting indices. So it's sometimes you really nicely see when you do the pre-dilatation and you check the TPR, and you can see that the flow has improved nicely. And also, of course, after the stent, if you reach 0.9, then you can say that the result is really nice. So yes, if I use the pressure wire for PCI, I do resting index quite often.
Yeah. I think this is also it's very interesting what to know this, because I don't know if I haven't found the publication so far, but I remember that last year in TCT there was by Alan Jeremias, there was a presentation that post PCI physiology revealed up to 25% of the cases a residual stenosis that has to be treated in terms of complete revascularization. So I think, especially with the diastolic resting indices, which are easy to use, and with the new technologies, it is very important to be sure that when you don't rely on the optical result or in the optical baseline at the beginning, that you don't rely only on the optical result at the end of the intervention. So maybe a question to the both of us who are using the Optiwire 3 for a couple of time. The question was, what about kink resistance? So what's your experience, especially if we compare it down the timeline from the first pressure wire? So maybe Ewald, would you like to start and comment on this?
Yeah, I think the wire behaved very resistant to the jading. I looked at the wire after I pulled it out. There seems no damage on the distal coil. It seems to slide very easily behind the stent, even though I have done a very high pressure pot, a 4.5 millimeter. So my first impression was that it's a stable wire that can be used again. Further, I would like to come a little back also to the previous question. I really agree on this, that when you go down in the vessel and you measure the physiology and it's significant, make a pull back, trying to identify which part you want to stent. We always tell each other that angio cannot tell us how significant the stenosis is. So we want to cover the part that is flow limiting by the pressure wire. Also, the pullback can tell us the start and the end of the stent, so it can be a predictor for the post-stenting physiology that we are getting above the 0.9 that is associated with a better prognosis. So you should extract all the information you can, not only that it's significant distal, but where is the pressure drop.
So I think what you just mentioned, the pullback, is one of the key lessons that we've learned from all the physiology over the last few years. However, just if you go, for example, for the LED and they have a mid-LED lesion like the one that you treated in this case, and you have upfront, say, a DPR of 0.62 at this lesion, and then you dilate it, and you have a clear resolution of the pressure drop, but you still, after your dilation, have, say, a DPR of 0.87, and you feel like it's a gradual pressure drop from the ostium because there is no significant lesion anymore in your pullback. You're happy with this, even if it's not a DPR of 0.94.
So I think that one of the advantages of doing the pullback with the diastolic pressure is that we don't have this crosstalk. So if we have two lesions and we treat the one, maybe because of increasing the flow to the double, then the pressure drop will increase on the more distal lesion. So by doing a pullback with diastolic ratio, we can identify without crosstalk where is the pressure drop and do a much more accurate stent planning upfront. So we are not disappointed. I know that a lot of operators don't want to do the post-PCI physiology because they don't want to be disappointed. But we should chase optimal result, and only having optimal result means that you should really identify what part of the coronary that should be stented.
Yeah, well, absolutely agree. Any comments from Pasi from your side?
Yes, I agree totally with Ewald. I would like to answer the previous question briefly about the kinking of the wire. So we have used Opsens wire 1 year now, and the earlier version we had some problems with this thing, but I believe that the new one, the Optiwire 3, now is much better. So we have now used 2 months for that, and I really like this this kind of wire with optic pressure sensing. So for instance, in our sensor, we are not doing that many earlier version of pressure wires. I mean, Abbott or Volcano. So I believe that there is a great improvement here in this wire, with this wire.
Another important thing to mention is that when you use this scaling technique, you are not able to get back and check for the drift before you make your decision, because you cannot get it down again. So you really need to have a wire that is stable to drift. And if you use diastolic pressures, the range that you are working in from 0.9 to 1.0 is very narrow. So you need to have a very stable wire without drift when you want to work with the jailing technique and diastolic indices. That's also some message I think we should share here.
Yeah, well, I think there's one thing to be aware that in many cases it's not a diatomic value, so it's not black or white. It's near 8.9, or if it's 8.8, it might be or it's 0.88, it might be acceptable as well. But however, I think you're completely right that the drift is a very important fact, and not so many people are aware that Opsens initially comes from the oil drilling business. So this pressure sensor is really it's derived from heavy duty stuff. And I think it's the advantage of this true pressure sensor compared to electronic devices that the drift is as low as possible, because the material stays more or less the same, even if it is in the circulation for a couple of minutes or even longer. And so when we're talking about kinking, I mean, the Optiwire 3 has a quite specific design, because it's one wire, if you want. It's a core design, and I think especially with the new one, the kink resistance has improved a lot, because that's true that initially this was sometimes a kind of a problem. So I think we answered the question about drift that came up as well. I would just like to ask one of my questions. And when we've been in Pasi's presentation, you showed this picture with your slide that DPR was 0.92 and the FFR was 0.77. So if the DPR is negative, do you always go for additional FFR?
Yes, this is a good question. Yes, I believe that I am using the cut point for DPR 0.99 or something. So if it's below 0.9, it's certain that it's the reason you have to treat that. But if it's somewhere between 0.9 and 0.95, then I almost every time do the FFR. And we see this kind of situation quite a lot, that you have a TPR 0.9291 and then the FFR is less than 0.8. So I tend to do FFR also a lot. So if it's about 0.95, then it's okay, but below that you have to rethink about the situation. What about Eva thinks about it?
Yeah, we also have this experience, especially in the LAD, because of the big territory that it can become significant. And also when we are in the left mains was excluded in many of the trials. So I think we should have as much information as possible. So I think when you are in a borderline scenario, you can add additional information and take the decision. Should also think about what are we treating? Are we treating angina? Are we treating prognosis? Or what are we treating? So we do a lot of FFR in addition to resting indices.
So just to fuel a little bit the discussion, play a little bit the devil's advocate. I mean, when we're talking about the LAD and we're talking about prognosis, I think the FFR cutoff is about something like 0.67. So, however, if we go for an FFR of 0.77, it's, if you want, it's still in the gray zone. So it's not below 0.75. I know that many operators feel exactly the same. And one colleague said, it's not in my DNA to let this lesion untreated, but I think it's still a dilemma. And if we look at the last data that we have from the people from King's College, from Shai Sam, who nicely demonstrated that deferring patients with a negative DPR, especially in the LAD, is safe. However, I think it also, well, surely depends on a little bit on the operator and his judgment and on the patient itself. So in the first case that we've seen, Eval's case, with the patient has no great other medical conditions, was not diabetic, maybe DPR and FFR are closer together than if we have someone who has a diabetic old lady with a very bad coronary flow reserve.
Yeah, I agree on that with the LAD, but I think also in the scenario where we have a STEMI patient that we want to completely revascularize, then maybe it's a little different with the cut point of 0.67. I'm aware of that from the meta-analysis, but that's maybe more in a stable situation. This lady is, the listening man is selected from a plaque rupture in the right, so he's a little more vulnerable. And if we look carefully into the complete trial, I think we can do FFR guided intervention and also angio-guided. But the advantage in this case is that you can really control what's going on in the bifurcation. So I think the pressure wire helped you to make the decision and stopping and not doing it too complex. Not doing it, ending up in a culotta stenting that is maybe not useful for this. So it's not only treat or not treat, it's also controlling the procedure and where to put the stents and how many stents.
It is also, I would like to comment a little bit, it is also interesting that, for instance, my case, it was an acute patient. Of course, STEMI was 3 days earlier, but I believe that there is evidence, and we have learned that if you measure FFR in the acute setting, it might be a little bit higher compared with if you measure that 1 month later or so. So in my case, FFR was 0.77, so probably after 1 or 2 months, it would have been a little bit lower. Who knows? But other issue is that I believe that in acute setting, the resting index is more stable or constant compared to if you measure that in stable situation.
Mm-hmm. Yeah, I think we all agree that the DPR is less affected by underlying comorbidities. That's absolutely right. So I would like to go ahead with the questions from the audience, and I would like to cite this one because there's someone who also asks you, thanks you for your nice presentations. And I think that's something that has to be told. You would like to know how nitro given during the PCI affects the post PCI pressure measure. And I think this is this indicates a very important thing about how to do the measurements at all. So would you like to comment on this? So
I think you should give nitrate in both the resting indices and also in the FFR, because you have to dilate the epicardials as much as possible. So you should take away the resistance in the epicardials that are not resistant to nitroglycerin. It's also important that when you give that, you also inject saline. So you have to wait for the measurement of the resting indices, because saline in itself and contrast in itself will dilate. So you have to wait for a stable condition. Typically, we wait 2 minutes after we have given nitro before we take it. And we do it very early in the procedure. So it takes some time to bring down the wire. And we give it up front to avoid spasm during the instrumentation. So I think it's you should use it in every physiology measurement. It's my suggestion.
yeah, well, I think that's absolutely important, because the wire in itself might well start spasm. So nitro for FFR, it's mandatory in order to have your full adenosine potential used, and for the resting indices, it's, as you told us, important as well. So don't leave this aside. The question arose: so do we need hyperemic indices anymore? So what do you think about that? So let me. I would like. Yeah, please, Pasi.
I believe that we still need FFR. So of course the resting index is very fast and easy to measure, but there's so many cases where you are and the gray zone, so you really need to have a FFR as well. So I still use that and believe that.
Yeah, we also need longer follow-up in the IFR trial. So we have to be sure that they are interchangeable, that we can use them both. But I think we need FFR until we have 5 years follow-up in the other trials. Also, we have had cases, younger patients that have angina with a normal resting indices, but with an abnormal FFR. These are person that want to go very physically active. They really need to avoid a pressure drop during exercise. And so this is again, are we treating angina? Are we treating prognosis? So when we're treating exercise-induced angina, it can be helpful to stent flow-limiting stenosis in a stress situation.
Yeah, completely agree on this. I think there's one thing that is important to keep in mind. It's better to have one of the big advantages of the resting indices is ease of use, and so it's better to use this instead of not using anything, because you don't want to go for ischemia. However, you're absolutely right. There's a growing body of evidence that the resting indices can be used in a couple of conditions. There's no data for the left main. That has been a little bit of black box, I think, for the last years. But so far, maybe the time will come, and I hope you agree that the resting indice will be the mainstay. But there's some need for hyperemia. So the next question was something about the performance of the wire. How does it perform in calcified lesions?
Well, as mentioned earlier, we have used this wire quite often. So actually, it's the default wire in our institution nowadays. But I feel that it's almost like a basic PCI wire, like BMW or something like that. So it's really good. Also in calcified lesions. Of course, if there is a very tight lesion and or long, it may be challenging. But of course, if there's a tight lesion, probably you don't need any pressure wires. But I think that it's usable calcified vessels as well.
I think, and correct me if you feel it differently. I think one of the questions is sometimes not really the tight lesion that you really want to measure. It's to bring the wire far enough downstream the vessel, and maybe then it is really important that you have a wire that has a good maneuverability, where you can even, especially in the LED, negotiate loops or at least kinks. And I think in this case, the Optiwire is quite nice, because the tip load of 0.6 grams is very, very soft, and it's only 3 centimeters. So it's quite nice, and you can really use it in a variety of lesions that might have not been accessible for wires of the older generation before. But I think that's something that really everyone has to try to figure out, get confident with it, and get used to it. But I personally see that there's a huge development over the time line in say, how the wires came close to regular workhorse wires like the BMW that you said, or like the wires from Asahi. So what's the learning curve for optimum results? Is there one? So I see you're it's obviously not so easy to answer this question. So I give it to Pasi first.
Learning curve for okay. I don't know. It's really easy. That's all I can answer.
Okay.
For me, also, I'll say it's plug and play. So I don't think it's like working with a workhorse wire.
Yeah. And what is also nice that in cath lab, the nurses, they like the system because it's just one plug and that's it. Everything is, the setup is ready, so it's really fast. So I like the system, the whole system.
Yeah, well, I absolutely agree. I think this is I'm not getting tired of mentioning it again and again. I think ease of use is what's really important in the cath lab, because we're all busy, and if you have to rig up lots of things before you can really work, it's quite hard. So the last question that I chose, and then I think our time is about to be over, is maybe a general question that should be asked to you. Despite the nice survey results in complete trial, physiology is barely used in STEMI patients. So how much do you think depends on the culture? Should there be any ESC recommendations who should address that?
I think we need to do complete revascularization stimulation from the trials we have now. And of course, you should treat the right stenosis, and you should do a good job without complications. So for me, I think it's we have to do it.
Yes,
I know that the full Revas trial was stopped prematurely because we could not randomize to not doing full Revas because of the complete trial.
Yes, and I also agree that, as mentioned earlier, in acute setting, I believe that the resting index is more reliable, probably, compared to FFR. So, but of course, we need more data and longer term follow-up about that.
So from your daily practice, if you have a patient presenting with STEMI or ACS who obviously has the one culprit lesion, but a couple of lesions that seem to should be treated at least in the same stay, and you're not absolutely sure if the physiology might be influenced by the acute setting, would it be an option to do the culprit first and then bring the patient back to the cath lab maybe 2 or 3 days later to do the physiologic measurements?
Yeah, we have this setup now that we are doing it that way. If it's if it's an easy non-culprit lesion, you have a good result in the index. If the patient is a little or low pressure, you haven't opened it right. There's no reason to stress the left coronary system. So then we bring the patient back day 3, and the patient is discharged on day 4. So it's a very patient-friendly way of doing it, to do it in the same hospital stay.
Yeah, I mean, I know that both of you are using the transradial access, which is, well, something that made decisions like that much easier, because it's so easy to bring the patient back, because you don't have to have closure devices or putting in the bandage for a couple of hours. And I think this makes the decision to postpone a second look for up to the next 2 days or next 3 days again much easier. Well, I think that's all the time that we have today for this very interesting discussion. And I think there were a couple of very interesting points today. And I would like to remind everything from the audience that today's proceedings will be shortly be available on demand at www.radcliffecardiology.com. So please go there and watch again. You can see all the questions asked and answered again. And well, before we go, I would again like to thank our faculty today for their fantastic contributions, for their nice work, and for the very good interaction and the question and answers session.
Thank you, Tim.
Thank you for having us.
And well, our thanks also goes to Opsens Medical for supporting today's event. And well, finally, and last but definitely not least, thanks again to the audience. We were not able to answer all the questions. There are still a couple in the queue, but I hope we could cover the most important ones. And thanks for joining us today. And we hope that we could support some insights and met our objectives. And I would just like to briefly do a small summary and just get to our closure. And I'd say, well, thank you and goodbye, and thanks for being with us, and take care. Bye-bye. Thank you.